precarious Wi-Fi. So I am. You've done a quick change there to the agenda, Steve, with my name. So I'm stepping in for Sian this morning, but Sian is around and will be walking us through some national updates. So today's ICS catch-up call, we're joined today by Emma and Jackson from the Derbyshire Carers Association, who are going to be talking us through their H Connect project to raise awareness for healthcare professionals in hospital settings. So just before we hand over for the bulk of today's session to Emma and Jackson, I think, Sian, you've got some national updates you just want to run us through.
Yeah, thank you. So welcome everybody. Yeah, I'm Sian Harris and I work with Ellie and Steve in the Commitment to Carers workstream in the national team of NHS England. And I'm just going to quickly run through some things that we're working on at the moment, just to give you a flavour of what we're concentrating on whilst still going through this interesting time of restructuring at NHS England and with the department. So Jim has been leading a piece of work around refreshing what were previously known as the GP quality markers. So this is kind of setting some standards and some guidance about how general practice could implement a unpaid carer friendly practice around identification and support. So that has been doing really well. There's been quite a lot of engagement around this. Probably some of you have been involved in that. So at the moment we're on the final kind of draft write-up. It's going to be called Supporting Carers in General Practice, a Framework. So we have heard loud and clear, and I completely understand that actually quality markers probably wasn't the right name for this framework. It didn't really suggest what it was all about. So that's one of the main kind of takeaways, and then updating. So thank you ever so much for anybody who's been involved in that. We're really excited about being able to take that forward via our comms approval. So watch this space. Ellie and Steve have been leading around young care engagement sessions, and we've had some really strong engagement with young carers. We had the cross-government summit on the 19th of January and had some brilliant conversations, really good support across the government. We had Department for Education attend, Works and Pensions, CQC. We had a really good coverage. So Ellie's doing that final write-up to hopefully launch some guidance on Young Carers Action Day on the 11th of March. So no pressure, Ellie, as she just finishes off before she goes off on maternity leave and leaves us. So there's some work we're doing around digital, so doing some exploratory work with the Digital Home and Communities team, exploring unpaid care identification, how we can progress the NHS app and My Carer, and a lot of other work. And it never ceases to amaze me, the complexity around digital and identification. So hopefully we can progress that with some pace. Scoping with stakeholders options for unpaid carer support. So this is a piece of work about actually looking at what is out there to support unpaid carers to look after themselves and deliver the care that they do. So if you have any packages of support for unpaid carers in training around that, please do reach out to someone within our little work stream so we can really spotlight and shine light on that practice. It is still the ambition that we will have a 2026 Unpaid Carers Conference later on this year. And we feel that not only does it need to be there because it will be Steve's 10th, and wouldn't it be a shame if he didn't get to a point of having the 10th to support, but actually this is a really important time as we bring NHS England and the department together, that we can land some of the amazing work that's been done for unpaid carers, and make sure that this is continued and it just doesn't get lost with all the restructuring, reorganisation. So we feel that this is a really, really key point where we can be handing over some of the strategies, the policies, the direction, what we've been hearing from unpaid carers, what's important to them, and where that goes next. So it will be a pretty targeted audience and content, so we can deliver that ambition. And then the bi-monthly Lunch and Learn, the next one's on the 18th of March, and we've got Mobilise and SMS identification, state case study, and dynamic carers assessments. That's a sharp pingy kind of title, but I'm sure it'd be great to hear from Mobilise around that. So I think that's all my updates, unless I've missed anything out. Ellie and Steve, do come in, please.
No, I think that sounds like everything. Thank you, Sian, and your Wi-Fi held on. Brilliant. So just as I should have said at the beginning, but Steve has kindly popped in the chat box, we don't have a chance to go around and introduce ourselves all in person today, just due to timings. So if you can just pop who you are and where you're calling in from in the chat box, that would be great, just to know who we have in the room. And then without any further ado, I'm going to hand over to Emma and Jackson from Derbyshire Carers Association, who will be walking us through their project till about 10 to 11, and then we'll have around 10 minutes at the end for question and answers. So thank you both.
Oh, thank you ever so much. Thank you for inviting us. I'm not going to lie, I am a little bit nervous, so I do hope that we can show you what a great project this is, because we are incredibly proud of it. My name's Emma Handley. I'm a manager for Derbyshire Carers Association, and we support carers across Derbyshire, and we're soon to also start a contract in Derby City supporting carers. I'm here today with my colleague Jackson, who I will be passing over to halfway through the presentation, and he's going to tell you a little bit more about the research that's attached to this project. Next slide, please, Steve. Thank you. So we were really lucky a couple of years ago that we were approached about being part of the Accelerating Reform Fund. And the 3 projects came from this fund. 2 of the projects we lead on. One of them is H Connect, the other one is Reimagining Carers Assessment. And then there's another project that sits within Derby City, which is led on by Community Action Derby. The money's come from the Department of Health and Social Care across Derby and Derbyshire ICB. And we lead on both of the projects for Derbyshire and Derby when it comes to Reimagining Carers Assessment and H Connect. The projects haven't been going long. They started around about January 2025, and they are due to end in August 2026. And we are currently looking at additional funding to hopefully continue this project. So the rationale behind H Connect was carers provide a vital day-to-day knowledge about patients that clinical records cannot capture. NHS England's Carers Toolkit highlights that supporting carers improves wellbeing for both carers and families. New research, it's not so new research now, estimates that the economic value of unpaid care is around about 184 billion per year, and that actually works out around about 504 million per day. And we're now looking at making this more than just a pilot, but we want to actively support this so it can be part of the wider strategic priorities of the ICS and adult social care. Next slide, please, Steve. So it's no secret that supporting carers when it comes to hospital admission and hospital discharge has a significant impact on the system. And we know that identifying support and involving carers in discharge planning reduces length of stay, prevents avoidable community and urgent care services, all of which directly save system money. Now, we're very lucky at Derbyshire Carers Association that we have another project which is called Carers Voice. So before we started this project, we already had a lot of insight that we can use to have a look at how we were going to design the project going forward. We knew that there was a huge gap in hospital discharge, and quite often carers felt like they were failed when it come to the support for themselves and their loved one. Some of the things that carers told us: I don't feel listened to, and no one has ever asked me if I'm a carer for my husband. My husband, with an end-of-life condition, was discharged in the middle of the night in winter wearing only a t-shirt. The care and compassion I gave as his carer was completely disregarded. Information was withheld, inconsistent and rushed. I felt like I was part of a relay race. The support for carers stops once your loved one is admitted into hospital, and we were continually told about lapses in medication information and missed opportunities. This was a reoccurring theme. When I pass on to Jackson, he will tell you a little bit more about the themes that have been coming forward as part of our research project. Next slide, please, Steve. Oh, bear with me. So the core objectives were to identify carers early in the hospital journey, involve carers meaningfully in treatment and discharge planning, reduce hospital readmissions through better carer support, and improve outcomes for carers of all ages, backgrounds and communities. Next slide, please, Steve. So it was really important to us that we started small. We have led on numerous projects and we have worked with hospitals before, but we hadn't done anything quite like this. We'd been visible, we'd done information points, we had done drop-ins, we had sort of had hot desking within hospitals. But in terms of what we wanted to achieve from this pilot, this was something new to us. So we wanted to start off with a small handful of pilot sites, and we wanted to learn and build on them. So we started off with the Macmillan unit, Cubley Court, Radbourne unit, Ward 3 and Ward 5 at Florence Nightingale and Cavendish Hospital. And we also worked with, and still are working with, the Care Transfer Hub in Chesterfield and the dementia team. So we've got different streams of work that are currently happening. These pilot sites that we started with around about March, April 2025, we started to come to an end of working with them around about December, January time. And from there, we're really happy to say all but one of the pilot sites have worked towards being a carer-friendly ward, which I'll tell you a little bit more about in a minute. Unfortunately, Radbourne unit wasn't able to continue working alongside us, and it was because of the complexity of the ward and the demand that was on the staff, and they just didn't feel that they had the capacity to work with us at the moment. But it is something that we're revisiting down the line. Next slide, please, Steve. So, as I say, we wanted to do something different as part of this pilot. We knew that there are other models out there. We know that there is some value in being visible, but you only ever capture who is entering the hospital that day. We know that there's some value of carers champions, but we also know that if a carers champion goes on annual leave or if they go off sick, then there is no support there for carers. So we wanted to tackle this from various different directions. So the first thing we did for all of the hospital pilot sites that come forward, we allocated a hospital liaison worker, and the hospital liaison worker is there to work closely with the hospital site to support them to work towards being carer friendly. Then that can look various different ways, but one of the things that we was asking for from all hospital sites was that they engage in carer awareness training, and we wanted as many staff as possible to attend those training sessions, and I do have some data and numbers at the end of the slides. One of the other things that we were asking from pilot sites was that they pledge to support carers. So what can they do within their ward their service, their site to support carers that they're coming across. Now, every ward was different. So what we ended up having was various pledges. So we had some carers that didn't have carers boards, some wards that didn't have carers boards. So they designed carers boards to ensure that carers could self-identify. We had some wards that introduced carers coffee mornings. We've had some wards that have gone as far as introducing regular carer support groups. Some wards have introduced carers clinics where they book appointments for carers to have one-to-one support, and some wards have introduced drop-ins so carers can be captured as they're coming in and out of the wards. One of the other things that we did as well, because we talked a little bit about the importance of being visible. So as well as allocating a hospital liaison worker, we've also allocated a carer engagement worker to any of the wards that want to work with us. So where there's a coffee morning, a support group, a carers clinic or a drop-in, there is also a carer support worker who is able to offer that one-to-one support to any carers that we're coming across. What we found as well is the engagement between ourselves and hospital wards have increased and improved considerably. So we now have health professionals that are contacting the hospital liaison workers and the carer support workers and saying, I've got carers, I'm a little bit worried about them, they don't seem to be managing, their loved one is due to be discharged, but we're worried that they're not going to be able to manage once their loved one is home. Is there anything you can support? And that's where we're stepping in. And what it also means is they're not sitting on a waiting list for someone to call them to have a look at how we can support them. We've also introduced accessible and inclusive posters and leaflets as part of this project. We've spoken to a lot of carers from diverse communities, particularly communities where their first language isn't English. And what we've learned is that actually we don't have to ensure that we have information translated into every language, but easy read documents seem to be what a lot of carers are requesting, because they say then that they can translate them themselves or family members can support them. So we're also making sure that all the wards and all of the sites that we're working with have accessible and inclusive resources so carers can self-identify. Alongside this, we've also introduced a professionals hub. Now, we know that there's going to be people that can't access our carer awareness training. So what we're doing at the moment is we're designing training videos which will sit on our professionals hub. So this works really well for health professionals who don't have the capacity to attend training, perhaps work shifts, work nights. They can go onto our professionals hub, they can access information, advice, guidance, resources, posters, and they will also be able to access our training videos. One of the other things we were really mindful of was that we know that this project is going to identify a lot of carers, both for Derby and Derbyshire. So we didn't want to create a bottleneck for our carer services, who we sit very closely with. So in Derbyshire, we've got Derbyshire All Age Carer Support Service, and we've been working really closely with them to ensure a smooth transition and referral pathway to make sure that carers have the appropriate support. And we've been doing the same with the carer service in Derby City, which is Universal Services for Carers. But we've also been mindful that we don't want to put extra pressure on these teams. So what we've done is, as part of this project, we were also able to allocate some funds towards community services. So we had a grants process that we introduced last June. We had a number of services that come forward that applied for small grants to support carers in Derbyshire and Derby as part of their existing services. And we now have 9 services that are providing additional support to carers across these areas. These range from peer support to craft to counselling to coaching. So there are various things that are happening. One of the things that are quite exciting is we have a carers podcast. And we are due to launch the first episode of this month, and the first conversation is all around what is a carer, how can we support carers to self-identify and see themselves as carers. All of our pilot sites that we've been working with, they all have the opportunity to work towards being a carer-friendly hospital. Carer-friendly hospital. So there is an award at the end of this. Where hospital wards don't have capacity, they can receive light touch support from us, so they can access the training. We can make sure they've got access to resources. We can support them with a carers board. But where hospital wards want to do a little bit more, and this is where they pledge to put something a little bit extra in place, they then are awarded with our carer-friendly hospital award. Next slide, please, Steve. It's just a couple of photos of some of the people that we've been working with. I'm really happy to say that so far we have had 4 pilot sites that have been awarded the Carer Friendly Award, and we do have a couple of more that are booked in over the next month or 2. Next slide, please, Steve. So this is a couple of things that we found when we've been working with the wards. And again, Jackson, who's going to talk in a little bit more detail. We have 2 phases to our research. The first phase is that we want to speak to around about 20 carers about their experiences of hospital discharge. Our second phase is that we then speak with health professionals and discharge teams. But this is some of the things that we found as part of our Carers Voice project when we started working with the wards. So hospital teams had not previously undertaken care awareness training. So we were coming across a lot of health professionals that had never accessed any care awareness training at all. Information displayed on the wards was outdated, and some wards had no information at all. We actually worked with a couple of wards, and there was one ward where information was as outdated as over 10 years. So the information that they had that was displayed for carers was no longer in use. Approaches to identifying signposting carers were inconsistent across wards and teams. We had hospital teams that were still talking about COVID-19, and they felt that since COVID there'd been reduced awareness of what was available within community services, and that they had limited knowledge of the carers services, both Derbyshire All Age Carer Support Service and Universal Services for Carers. Hospital teams was not fully aware of carers' legal rights to be involved in discharge planning. And this actually come to quite a surprise to a lot of people that we've provided awareness training to, is that actually carers, with permission from their loved one, do have a legal right to be involved in these conversations. Interaction with carers was limited, reflecting gaps in staff understanding and knowledge of carers' roles, and hospital teams reported lacking in understanding and confidence needed to approach carers effectively. I should add here as well that every health professional that we've been working with as part of this project has wanted to engage and support carers, and the people that we've been working with have been so passionate about learning more about carers, so much so that one of the things that we've also introduced is a program called Call for Carers, and it's a 6-week program where health professionals can book on sessions to learn a little bit more about what is available for carers within Derbyshire and Derby City. So we do the carer awareness training, but we've also gone a little bit further just so we can support health professionals so they can build on their knowledge as what is available, because that was one of the things that kept coming forward. Next slide, please, Steve. Thank you. So this is some of the impact and deliverables. This is between January 2025 and December 2025. We collate this quarterly. So this would have increased since we actually did this slide. So we've had a 58.82 increase in carers who heard about Derbyshire All Age Carer Support Service through hospitals, demonstrating significantly improved visibility and reach within healthcare settings. We've had a 25.6 increase in referrals from health professionals since the introduction of H Connect, which has shown that there is stronger engagement and also earlier identification of carers, which is brilliant. We've had 348 carers supported through H Connect. These are carers that we have actively engaged with as part of this project. So on top of this, we will also have carers that have referred into the service, self-referred into the service, that actually have been identified within a hospital setting that we don't know about, because as they're being referred, it's only being captured as a self-referral, and they're not putting on the referral form where they heard about us, or they can't remember where they heard about us. Quite often carers feel quite overwhelmed by all the information and people that are involved. So when they refer themselves to us, they can't always remember where they heard about us. So the 348 is the carers that we have actually actively engaged with. These are part of groups that we've attended, clinics and information stands, and any events that we've done as part of H Connect. We've consulted with 330 carers about their experiences of hospital discharge process, and as I say, Jackson is going to be speaking to as many as 20 carers. Care awareness training, which is the call for carer sessions that I mentioned that we've introduced, and so far we've had 166 health professionals who have attended. Over 120 carers supported between July and December as part of the H Connect community grant services. Over 650 resources have been provided to hospital teams, posters, leaflets, carers boards to support with the self-identification of carers, and 612 professionals have engaged through outreach and awareness activities, which have all been focused on how can hospital teams identify carers within their wards. Next slide, please, Steve. So
hi,
you'll be
everyone.
happy.
Oh, sorry.
Oh, sorry.
So I thought you handed over to me.
No, I'll quickly do this slide and then I will, Jackson.
No worries, no worries.
So as I said at the beginning, so we want this, we really do want this to be more than just a standalone pilot. The whole point of this project was to start small and to build on it, and we know that this has been a huge success. So alongside this, we wanted a research project so we can really evidence the difference that this project can make to carers, to their loved ones, and also save money. So the research project, the objectives were to gain insight into carers' experience of discharge process, with particular emphasis on the communication between themselves, healthcare staff on the wards and other multidisciplinary teams, understand the barriers and enablers of care identification within the discharge process, and from this we hope to develop a co-designed support research which is going to support hospitals within Derbyshire and Derby City. Jackson, I'm going to hand over to you. Thank you.
Sorry about that, Emma.
That's
hi,
okay.
everyone. I'm Jackson Pountney. I am the research associate for the H Connect project. So I'm essentially doing a deep dive into care identification and care involvement in discharge planning throughout the discharge process. So I ran a qualitative interview study to kind of explore this in more depth. Next slide, please, Steve. So far, we have interviewed about 8 carers. Well, these slides are outdated. I've interviewed 10 so far, so we're about the halfway stage at the moment. These were semi-structured qualitative interviews, so that means that there are set questions, but there's also scope to explore like novel topics within the interview. As Emma said, the focus was on care identification, communication between themselves and staff, and involvement in discharge planning. And the overall goal is to understand the barriers and opportunities that carers may experience in relation to these things. Next slide, please, Steve. So this is a brief overview of the findings I've found so far. These relate to both challenges that carers face and also opportunities for good practice. So in the following slides, I'll briefly unpack each theme in turn. So next slide, please, Steve. So the first theme we found, and probably the most important, and it comes as no surprise to you, that carers sort of feel invisible in regards to identification. There was no structured identification process when they were in hospital. So nobody asked them the question, do you look after someone? Are you a carer, etc. So there were no formal opportunities for them to identify. And carers were also unsure if they counted as a carer in terms of the criteria as to what a carer is. That they mainly saw themselves as a parent or a sister, and the caring role was a sort of extension of their parent or family or friend role rather than them being an actual unpaid carer. So this prevented them from self-identifying as a carer. Next slide, please, Steve. The second theme was around carer expertise and the care for being dismissed. So carers reported that they had quite a lot of intimate knowledge of the cared for, but this knowledge is often overlooked in consultations with staff. Um, Carers often didn't want to speak up because they feared it as being seen as difficult. They didn't want to get in the way or interrupt staff, etc., when they're on the ward rounds. There's also some instances of professional defensiveness, and this kind of blocked the communication between the carer and staff. But the most important thing to realise here is that professional expertise from the consultant or the nurse is equally valuable to the lived experience of the carer. You know, these are two sides of the same coin, and they should really be working together rather than being in conflict. Next slide, please, Steve. The third theme was around communication breakdowns between carers and staff. So carers often received mixed messages from staff, whether that be the condition of the cared for or discharge planning, if there was any conversation, which often led to confusion and frustration from carers. The wards are often hard to reach as well outside of visiting hours, and this led to a lot of anxiety in carers, wanting to know how the cared for was doing. Carers often receive no written information about discharge, what to expect, support services, etc. This kind of left them in a bit of a void post-discharge, and this led to emotional and safety consequences for both the carer and the cared for. So, next slide, please, Steve. The fourth theme was around rush discharge. Carers received little or no notice a lot of the time when the cared for was being discharged. Their readiness to care for their loved one at home wasn't checked throughout the discharge process. This led to a lot of emotional distress and frustration, as carers often felt unprepared for the role of caring after discharge. This is exemplified by the quote on the right. It wasn't discharge planning, it was just discharge. So carers are not feeling like equal partners in the planning process. Next slide, please, Steve. The fifth theme, this is where, oh, sorry, you've gone back, I think. Thank you. So the fifth theme, this is where the cascade of problems really occurs. Carers absorb all the burden. Or when the system goes wrong, the carers have to compensate. They have to catch errors, coordinate care, manage complexities, and this is a huge emotional burden on carers. And this is where we often see breakdowns in the caring relationship because of the previous problems I've just described. This is again, this is exemplified by the quote on the right. You just end up dealing with it because there's no support anywhere. Or after discharge, like there's just this void where carers receive no support. Next slide, please, Steve. However, it's not all bad. There are instances of good practice. It's just these instances of good practice. Sorry, they're inconsistently applied. They're not completely absent. So when staff spare the time, they listen to the carer, they value their input. This makes all the difference to carers, and that oftentimes that is all they want. So we just need to see these instances replicated consistently across the board. Next slide, please, Steve. So if we sort of zoom out from the themes and look at the overall picture, these themes sit within a system context, which is that there are busy wards, care is often fragmented, and there are discharge pressures. So this suggests to me that these problems that carers are facing are not the result of individuals and their practice, it's the result of a system that doesn't give them space, doesn't give staff space to identify carers and involve them. So the overarching problem, as Emma has said before, is that care is not identified early enough in the hospital process, and this leads to the cascade of problems that I've described through the themes, which then results in overwhelming carer burden, and then the carer feels like they just can't cope anymore and they break down. Next slide, please, Steve. However, another way to think of it is in a sort of health psychology framework. So it's called ABC, so it's antecedent behavior consequence. So the antecedent is this system context, which is creating too much pressure, and the overarching problem of care has not been identified early. This then leads to behaviours, the care has not been identified, expertise dismissed, comms breakdown, etc. And the consequence is the overwhelming burden that carers face, and then that could lead to readmission into hospital, which can be prevented. Next slide, please, Steve. So these findings were mapped onto what's called the COM-B model, and the COM-B model states that there are three components to any behaviour: capability, opportunity, and motivation. So if you imagine the behaviour is care identification, someone needs to be capable of identifying the carer in terms of the knowledge, what counts as a carer. They need the opportunity to identify the carer, which, as I said before, the system doesn't create that opportunity, so that therefore the carer has not been identified. And they also need to be intrinsically motivated to do so. Next slide, please, Steve. So what I found was opportunity is the major barrier, as I've just said. It's a system that has too much pressure and doesn't create space for staff to identify the carers. It reinforces a sort of task first, talk second culture. And this then leads to not enough carers being identified. There are some capability barriers, but this is largely being addressed for our care awareness training. Next slide, please, Steve. Yeah, so why does care identification fail to occur? As I said, there are some capability barriers. These are largely being addressed for our training. Opportunity is the major one. There's no routine prompts to identify carers. The busy ward environment limits time and privacy to have those conversations with carers. The key conversations also happen when the carers aren't present. It's just the conversation happens with whoever is present with the cared for, and they may not necessarily be the carer. So therefore, the carer misses out on all that important information. And there are also some motivation issues in that as well, such as professional defensiveness, blocking collaboration. And then the outcome of that cascade is that carers are not identified, leading to exclusion, unsafe discharge, and emotional distress. Next slide, please, Steve. So what does this mean for systems and services? Like, we need routine care identification at the earliest point in the hospital journey. We need to improve communication processes between staff and carers. You also need consistent discharge planning, and what I mean by that is when the carer is consistently involved in the plan and they feel like an equal partner. And staff training may be needed to facilitate this, but I'll know more about that once I've completed phase 2. Next slide, please, Steve. So preparing for phase 2, as Emma said, the next phase of the project is to interview healthcare and social care staff in relation to care identification and discharge planning in hospitals. We'll be looking at these three main things here. So staff barriers, understanding workflow pressures and additional training needs. This will help us understand the acceptability and feasibility of then implementing any further resources, such as a discharge toolkit, which we'll talk about in a second. And when we can also see the complete picture, not just the carer's perspective, but the staff as well. So it gives us this holistic picture of what's going on in hospitals in relation to discharge planning and care identification. Next slide, please, Steve. So these are some preliminary ideas I've got for a discharge toolkit. Oh, so it's gone back. We're going to embed a carer ID question, so that staff know to ask the carer, do you look after someone? Do you help them with this, that, and the other? Are you a carer, etc. So that conversation can then take place. It provides the foundation for it. A discharge involvement checklist to ensure that the carer is involved in every step of the way, so they are fully informed before discharge happens, which then leads to the discharge readiness tool. Are the medications explained? Is the care package in place, etc. And then also some written information for carers to take away, because without that written information, carers are just relying on their memory of what happened in hospital, which is quite often a blur, so they may miss important information that's needed. Next slide, please.
Oh, thank you, Jackson.
Yeah, sorry.
Yeah. Oh, we've gone back. Oh, cheers, Steve. So yeah, just a couple of things about next steps. Obviously, Jackson's mentioned that we will be moving on to phase 2, which involves us interviewing healthcare professionals and also discharge teams from adult social care. We're introducing a digital care awareness training offer. This will be on our professionals portal, and there'll be bite-sized videos for health professionals to access. This fits bestly for those that aren't able to access our call for carers or our in-person care awareness training due to working shift patterns or nights. We're going to be working very closely with Live Life Better Derbyshire, and we are delivering a campaign across Derbyshire and Derby called Know Your Numbers, and that's about the health of carers. We're going to widen the HConnect reach to support more wards and services, and we've already started to do this, and we're working with probably double the amount of wards now that we've listed in that slide where we've mentioned the pilot wards. We're expanding carer resources to include more of the easy read stuff and translated formats to ensure that we're capturing all carers, particularly those from diverse communities. We are delivering care awareness training sessions to care transfer hubs. This is something that we're starting at the end of this month, and we're starting with discharge teams and care coordinators. We're involved in the training for the 4th year medical students as part of the expert experience training programme. This is something that we're really excited about, because we also want to change a culture. So we want to be able to capture health professionals at the beginning of their journey. So as they're accessing training, they can start thinking about carers straight away. We're also working with the patient experience team at Derby and Burton hospitals, and we're hopefully going to introduce a carers charter. And we're developing a partnership with Signet Healthcare alongside the Triangle of Care, which we've already started to develop some stuff as part of that, and we're also jumping on some of the training that they've got on. Steve, I'm going to say next slide, but I actually don't. Yeah, there isn't one. So we'll go to questions. Thank you.
Thank you so much, Emma and Jackson. There was so much fantastic information there, and some really exciting stuff in your next steps too. So it'd be great to have you back at some point, hopefully, to hear about how that goes. I'm really interested as well to see that you're looking at embedding it within the 4th year medical student training, because I think that's so fundamental to catch people right at the start of their careers. I'm really enjoyed seeing your impact slide as well around increasing visibility, but also thinking, as you said, about how that translates into referrals into the services and whether the services actually have capacity. We talk a lot about the so what question. We're constantly talking about driving up identification, but then what? And it's really great that you're thinking about those in tandem. So what a fantastic piece of work. I can see there's been a couple of things pop up in the chat box, and Jackson, somehow I think you're keeping on top of replying to them, which I can never do those two things at the same time, so that's fantastic. We'll come to questions if people want to pop their hands up or put things in the chat box. So Caroline, I can see that you've got your hand up. Do you want to come in?
Can I just say, it warms my heart to actually hear that something is going to happen about training staff. They need it, they want it, and that is, I think, fundamental. I think the whole scheme is interesting and very good. So but having been campaigning for carers for 20 years, is actually, I get terribly depressed when we're faced with more documents, more intentions, and absolutely be nothing happening. And so this sounds really good. And I'm trying to get to the heart of professional training for health and welfare staff in Westminster, but it's jolly difficult to find out who's responsible.
Thank you, Caroline.
Thanks, Caroline. And Kate?
Hi there, thanks very much. That's really, really interesting, and obviously some great work. And it's really good that you're kind of backing it up with research, which is always a real asset. So my question was really, because we're trying, well, we've been running something similar where I am down in the southwest in Plymouth. But one of the kind of challenges we've had is around access into the hospital. So we've got our VCS provider that delivers the a hospital-based carer service, and we have worked in the past with a patient experience lead, but sometimes because she's so kind of pressed in other ways, because carers is only part of her role. So there's just challenges somewhere in trying to access, and sometimes the teams might go onto the wards and the staff were like, well, who are you? I mean, even though they've got kind of uniforms that they've kind of got, that they worked on getting, that kind of identifies them as the carers liaison. So I just wondered, when you initially set up the service, who did you liaise with there? Because obviously for you to get access, and who is there someone kind of championing it to kind of help, your access? That was my question. And then just another thing that we're doing is that they're setting up the Epic system, which is like the data, the data collection system, and that's being implemented into the hospitals across Devon. And as part of that process, they're trying to build in something around carers. So I don't know whether there's anything you've had kind of similar in terms of the the data systems used. Thank you.
Hi, Kate. I'll be honest, at the beginning of this project, we did actually think that it was going to be harder than it was. But I think what helped was we used the insight that we had. So because we already had that project, which is Carer's Voice, we had so much insight to go to meetings and health professional leads with and say, this is what carers are telling us, this is the impact, these are the examples of the sort of carers that are coming through for support. And we had so many stories of carers calling up the carers service and the difficulties that they were sharing with us as a result of a poor discharge, that really helped when we went along to these meetings. And we went to various meetings. We went to discharge improvement teams. We went to our neighbourhood alliance meetings. We also having very supportive funders and commissioners that was also very much championing this project as well, and getting people on board for us. But one of the big things that really helped us was that, and it's the reason we did it, is that we started so small, because as well as starting small, it meant that we could learn as we go along. What it also enabled us to do is to then use that as evidence. So we were then able to go along to other meetings or talk to wards and say, well, Ward 2 and 5 within Florence Nightingale are doing this fantastic work. This is the difference that it's made. This is the impact. This is what we're seeing. And because we were able to evidence it, and what we have found as well, it's very similar with our GP work that we do. Wards can be quite competitive with each other. If they hear that one ward is doing something, or one site or team is doing something, and they're doing so much better than this one, they tend to want a bite of that as well. And we find that with the GP work that we do. So when we're talking about the work that we do with GP practices, we will use an example within another GP practice that is doing X amount of work. And that tends to sort of mean that people want to get involved as well. So I think it's because of a couple of things. I think it's because we've got very supportive funders and commissioners, and they've been shouting about this project. It's because we've used insight that we already had of what carers was telling us, and the impact that poor discharge actually has, and also how it does lead to readmissions. And then the other thing is we started small and we used it as evidence. So they're the three things that helped us, Kate. In terms of sort of, what was it, you mentioned something about ethics, was it about?
Oh, sorry, no, it's just called Epic. So it's
Epic.
a new client data, system that's being implemented, that's going to replace the existing one, within all the hospital trusts. And then in that process, they're trying to build in something around questions around care identification, which is obviously a really positive step. But I don't know if you have something similar.
No. Unfortunately, we actually come across a bit of a reoccurring theme within Derbyshire and Derby cities, that we're all using different systems. So we use something called Charity Log, and then we will have adult social care who use Mosaic, and then we've got GP practices and obviously health using something different. So none of the current systems are talking to each other. There has been conversations about this, but nothing has come from it. And it is probably one of the things, we know that there is so much more information that we can capture, but because we use different data systems, we're very limited. So we can only go by the work that we're doing within the hospitals, the engagement that we can actively collate, and the referrals that we are seeing coming through to the carer services in Derby and Derbyshire. I'm sure there'll be so much more rich data that we could collate if we were all using the same systems. But unfortunately, we're not.
That complexity in digital infrastructure is a logistical nightmare, I think, across the whole of England. It's a real common theme. So Nancy, I can see you've had your hand up a while. Would you like to come in?
Yeah, sure. Thank you. And thank you for sharing all that information, especially around the project. Just going back to the next steps, one of the things that you mentioned is around the videos. So currently I support carers in Frimley system, and we are delivering carers training in the acute. So targeting all the professionals, the volunteers, the students, everybody in the acute. And there's been a lot of interest in terms of engagement, because we're tagging the training onto the training that is already happening, because it's really challenging for professionals in the acute to have that time just to come away from the wards and attend training. And I secured funding to get this training to go on. So initially we did, I think, about 6 sessions of training, managed to get more money to put towards this. So I've got more sessions to run throughout this year until next year, April 2027. So we're staggering throughout the year. And because of limited resources, we did look at videos, because they were open to the idea. When I had a conversation with the acute, they were open to the idea of, if I have videos done, they can upload it onto their system and it can be part of the mandatory, because staff come in and go. Obviously, that did not happen. The conversation didn't go that far because I didn't have the money. So my question is, when you do your videos, is there an opportunity to share those widely, or even, I don't know, paying a fee towards that? Because I know it's really hard to start from scratch building those videos, and when they're already in place. I'm just looking if there's anything we can do to access the videos, be it a little bit of money towards it, anything. Thank you.
Nancy, I'm more than happy to follow this up with a sort of conversation, and maybe sort of have a bit of a more sort of in-depth conversation about this. You are right, we're coming across it a lot in it's brilliant. We've had a lot of people that have attended the training that we have done today, and we've done it over Teams, we've done it in person, but there are a lot more health professionals out there that we could capture if we did have a digital option as well. I'm more than happy to have a conversation about that, but also as well, it might be worth having a conversation about the cost towards it, because one of the things that we do, we're a charity, so one of the things that we constantly do as a charity is have a look, how can we get this free or done cheaper? What's the best way of us doing this? And it's not going to cost us a lot of money. So I'll be more than happy to share that with you as well, Nancy, in terms of how we've managed to do these videos. Okay.
Thank you.
Lovely.
Thanks, Nancy. And then I'll just bring Jill in for what probably will need to be our last question, just looking at the time, and then we'll bring today to a close. So Jill, do you want to come in for the last question?
Yeah, hi, thank you. Brilliant presentation. I just wanted to go back to discharge planning, and it's something that we are seeing all the time, carers not being involved and carers not being asked if they're able and willing to care. So just to share something that we did, we worked with the local hospital and looking at their complex discharge planning on the database that they use, and we had that question inbuilt into their discharge planning, was who the carer is and have they been asked if they were able and willing to care, and that they were quite happy to do that, and I think that's made a difference. So yeah, just sharing something that we kind of felt, because we're seeing that across the board, that care is being missed, and like you say, it's that revolving door becoming the next patient.
Yeah, absolutely, and you are right, Jill. That's exactly what carers was telling us when their loved one was being discharged, and we were having a conversation with carers, because they were calling the carer service because they were really struggling. One of the questions we asked them was, you asked if you were able to do your caring role? Were you asked if you could give up work to be a carer? Was you asked if you had any other responsibilities? And no, the answer is always no. No, I was never asked that. So that's the work that we're currently doing at the moment, is about how do we get that question consistently.
Yeah, and we found having that embedded within the complex discharge planning can be really helpful. So it becomes a routine, because I think, like you say, with training that there is good intention there, but I think sometimes with the rush to get people out and so much to do, it just gets missed off. But I think having it part of that form kind of brings it back to making sure it's embedded.
Yeah, I agree, Jill. Thank you.
Thanks, Jill.
Fantastic, thank you so much. And then looking at the time, I see that we have 1 minute to go according to my clock, so I think we'll have to bring today's session to a close. So just a huge thank you to Emma and to Jackson from Derbyshire Carers Association for such a fantastic presentation today. It's been really great hearing about the work over at H Connect, and hopefully we'll be able to bring you back in at some point in the future to hear about phase 2 of your research, Jackson, and how those next steps progress. I'd be really interested around the awareness training. I know that there's been a really sort of lively discussion in the chat box. If there's any questions that are unanswered, please do just ping me an email and we can follow up on those. Otherwise, Emma, it might be handy just to pop your email in for the connections with Nancy around the training. And I think that brings us to a close. So just a reminder, as Sian said at the beginning, next Wednesday, the 11th of March, is National Young Carers Action Day. So please do take the opportunity to sort of promote that and share any work you're doing around young carers in your organisation. From the national team, we will be launching our co-produced GP Top Tips videos, which has our 2 fantastic lived experience partners, young carers, sharing what would make life easier for them as young carers in primary care services. And I think, Steve, Sian, unless I've missed anything, that brings us to a close.
That's great. Thanks ever so much,
Steve's putting his thumbs up, so that means we're done. So brilliant. Lovely to see you all. Enjoy the rest of your
day. Thank you. Bye-bye.
Thank you so much, everyone.
Bye-bye.
Bye.
Thank you. Bye.